Hello guys and welcome back to Counter 10. My name is Ani and on today's episode we're going to be finishing off our renal series with our final topic looking at the countercurrent mechanism, production of urine and some applied renal physiology. This is also the last topic of the year and I'm sorry there's been a little bit of a break between our last two episodes. As always, we're going to finish off by looking at the previous SAQs and hopefully by the end of this episode you'll feel much more comfortable covering renal physiology. Like I've said throughout these 3 episodes, this is a really hard topic, one that I had to keep going over and over again, but hopefully today you'll start to see all the information we've covered in the 3 topics start to blend in and finally make a lot of sense together. So with that said, let's dive straight into it.
1, 2, 3, 4.
The first learning objective we're going to cover today is explain the countercurrent mechanism of the kidney. And before we get started on this, I do want to say there hasn't been a specific SAQ or Viva that's only asked about the countercurrent mechanism. It is linked and important to know when you talk about the concentration and dilution of urine. And the principles we explain here are really important to know because this is a really crucial part of what the kidney does. I really found understanding this mechanism particularly hard, but there is great diagrams in Power and Chem that help illustrate what we're going to go through now. In the simplest form, the countercurrent mechanism is the kidney's way of transforming the glomerular filtrate into either concentrated or dilute urine. And to do this, there's 3 important processes involved. The first process is the loop of Henle, which creates a high medullary interstitial osmolarity because of its selective permeability and is therefore referred to as the countercurrent multiplier. The second process is the vasorector, which runs parallel to the loop of Henle but in opposite direction, and this allows the medullary concentration gradient to be maintained and is therefore referred to as the countercurrent exchanger. The final important process is the role of urea, which we've touched on previously in our last 2 episodes, but is really important and is modulated by the effect of antidiuretic hormone and plays an important role in maintaining or increasing the interstitial osmolality, again due to the selective permeability by the effects on ADH having on urea. So to understand all these 3 processes better, we're going to go through them one by one so you really understand how the countercurrent mechanism works. To start off, you have to go back to understanding your basic anatomy and knowing that the countercurrent mechanism is made in the justamedullary nephrons, and these are the nephrons which have the long loop of Henle with a thick and thin limb. And remember, the medulla receives significantly less oxygen but has a higher oxygen demand compared to the cortex. So in clinical situations where you compromise renal blood flow, you're going to disrupt the ability of this countercurrent mechanism to work, which is eventually going to disrupt your ability to either concentrate or dilute urine. At the end of the day, that's the important clinical relevance that you're trying to understand when you're learning how the countercurrent mechanism works. So starting off and looking at the loop of Henle, we can say that the 2 limbs of the loop of Henle have different permeability. The descending limb is impermeable to solutes, but permeable to water, while the ascending limb is permeable to solutes, mainly through the sodium-potassium chloride pump, but impermeable to water. If we then say the fluid entering the descending limb through the glomerular filtrate has the same osmolality as the plasma, roughly 280 to 300, what happens is, as the fluid goes down from the descending limb to the ascending limb, we have a change in the osmolality. And this change in osmolality is only minor by a change of 100, but this is significant enough to start to develop an interstitial gradient. And where this change occurs first is in the ascending limb. As fluid travels up the ascending loop of Henle, the solutes sodium, potassium and chloride get reabsorbed, and they get reabsorbed into the interstitium. This means that the interstitium solute load is higher and the osmolality within the interstitium is also increased. It's initially increased from the osmolality of 300 up to 400, and in the ascending loop of Henle, the osmolality has dropped to 200 milliosmoles per kilo. What this has now achieved is a gradient difference between the interstitium and the contents within the loop of Henle. Therefore, the new filtrate, which is coming in through the descending loop of Henle, where there is selective permeability to water but not solutes, means we're going to use the osmotic properties of water to then draw water out from the descending loop into the interstitium, until the osmolarities here between the interstitium and the descending loop of Henle reach an equilibrium. And this means as you reach the apex of the loop of Henle, the filtrate within the loop of Henle is now at a higher osmolality than it was when it entered the loop of Henle. As it goes up the ascending loop of Henle, this process is again repeated. Solutes are drawn across into the interstitium through the effects of pumps, and this is when you need energy to drive this process, leading to a further increase in the osmolality of the interstitium, again by 100, and when the new filtrate comes in through the descending loop of Henle, water is again drawn out until an equilibrium is reached. Repeating this process multiple times allows the osmolality, which was initially 300, to reach at its peak a maximum of 1200 to 1400. And we say the system is really efficient because it's only using that small difference at the start and repeating this process over and over again to create a huge difference by the end. And that's why we refer to the loop of Henle as the countercurrent multiplier. If you then look at this diagram on Power and Chem and look at the final result, what you then see is in the descending loop of Henle, the filtrate which is initially coming has an osmolality of 300. The filtrate at the apex is 1200 to 1400, and then the filtrate leaving the ascending loop of Henle going into the DCT is roughly 100 milliosmoles per kilo. So that's the effect of the countercurrent multiplier, aka the loop of Henle. What's the role of the countercurrent exchanger, aka the vasorector? Well, to put it simply, this is going to utilize the gradient that's been created to either reabsorb a lot of solutes and water, leading to concentrated urine, or not absorb a lot of urine and water, leading to dilute urine. And the way it does this, and this is the most important thing to remember, is that the vasorector runs parallel to the loop of Henle, but in the opposite direction. And with this, it has no selective permeability. This means that it can absorb water and solutes all the way through its descending and ascending limb. So if we look at the vasorector at the start, when it's running parallel with the ascending loop of Henle, here in the interstitium, you have a high number of solutes, because remember, the role of the ascending loop of Henle was to reabsorb the solutes, and therefore there's a gradient for solutes to go from the interstitium into the vasorector. However, in reverse, there's an osmotic gradient for water to go from an area of low concentration to high concentration. So water leaves the vasorector and goes into the interstitium. Meaning that as we reach the apex of the vasorector, its osmolality is also increasing, matching the osmolality of the apex of the loop of Henle. As that vasorector ascends, so therefore it's running parallel to the descending loop of Henle, now that interstitium, which has lots of water but not much solutes, means there's a gradient for water to be reabsorbed into the vasorector. So that water that was initially lost at the start is now reabsorbed. And by the end of the vasorector, the osmolality is only ever so slightly increased by what the osmolality was at the start. At the start, it matched plasma osmolality of 300, and we say at the end, it's roughly only slightly increased up to 320. The other important thing is that all these processes of water and solutes moving into the vasorector is a passive process, and therefore it requires time. What this means is that blood flow in the vasorector must be slow to allow this to occur. So the last important process in the countercurrent mechanism is the role of urea. And you could argue this has the biggest role in either producing dilute or concentrated urine. This is because the osmolality within the interstitium is only 50% attributed to the contents of sodium and chloride. The other 50% come from the contents of urea. And you guys will know by now that urea is freely filtered by the glomerulus. What then happens is a manipulation of how much is reabsorbed and how much is secreted back in. At the proximal tubule, you'll always get 50% reabsorbed. This urea entering the loop of Henle has only a slightly greater osmolality than the plasma, and the loop of Henle and the collecting ducts are normally impermeable to urea. But under the effects of ADH, urea can be reabsorbed at the medullary collecting ducts. And if urea is reabsorbed, what this does is that it enhances the osmolality of the interstitium, therefore increasing the effect that solutes like sodium and chloride are trying to have by increasing water reabsorption via the creation of a large interstitial gradient between the apex of the loop of Henle and the top of the loop of Henle. And that's really as simple as I kept it when it came to urea. I thought of urea as this additional tool that helps to enhance the interstitial gradient, therefore making the difference between the apex and the top of the loop of Henle larger, and this effect is driven by the effects of ADH, creating urea porons within the medullary collecting duct, and you see this effect when you need to reabsorb more water. Therefore, the net effect will be concentrated urine that you'll be peeing out, and increase reabsorption of water, therefore increasing your plasma volume. And this segues really nicely to then talking about the production of concentrated versus dilute urine, which is a repeated question in the ANSCA exam. And if you understood that last concept of urea, it's really as simple as that. When we talk about concentrated urine, we're talking about states where you need to preserve water. Therefore, you're normally in a shock state. In order to achieve this, you need to maximize that interstitial gradient, and the highest concentration you can achieve at the apex of the loop of Henle is roughly 1200 to 1400. You might then be asking, how is it that we're getting water reabsorption occurring despite the osmolality of the fluid leaving the ascending loop of Henle being only 100? And this is because ADH is mainly having an effect in the collecting ducts. And what it's doing in the collecting ducts is that it inserts those aquaporons that lead to water being reabsorbed within the collecting ducts into the interstitium. And the water will be reabsorbed here because within the interstitium, you created this gradient as the collecting ducts go down, where the interstitium osmolality is nearly 1200 to 1400 milliosmoles per kilo. Therefore, water is going to follow its path of osmotic gradient, and as water gets reabsorbed into the interstitium, it's then going to be reabsorbed via the vasorector, increasing the plasma volume. In contrast, when you want to make dilute urine, the countercurrent multiplier doesn't have to work as hard to create that gradient. Instead of making a gradient of 1200 to 1400 at the apex of the loop of Henle, it only may make a gradient of say 600 at the apex. What's leaving the loop of Henle in the ascending limb, entering the DCT, is still an osmolality of the filtrate being 100 milliosmoles per kilo, but you don't have the effect of ADH creating those aquaporons leading to reabsorption of water as that filtrate goes down the collecting ducts. This means that the water stays in the collecting ducts and you get a high urine output. And with this, we always say we have a minimum urine output that always needs to be excreted by the kidney. This number is roughly changed depending on the text, but the obligatory urine output needed to clear solutes is roughly around about 400 mils per day. And we'll review this again when we look at the SAQ on how the body produces dilute and concentrated urine. So with that, we'll move on to our next learning objective, which is explain the mechanisms involved in the regulation of renal function. And when I think about this learning objective, I think about another learning objective, which is explain the renal responses to hypovolemia. because I think these two things are intrinsically linked to the regulation of renal function. When you think about renal function, you can think about the kidney being involved in the whole body's homeostatic system when it comes to the maintenance of plasma volume. If you take a step back from that, you can think about the role of the kidney when it comes to maintaining cardiac output and maintaining MAP. And I think that's where you see the diagram for MAC 95 when you look at the related concepts regarding these learning objectives. It's a really complex diagram to firstly look at, but these are things that we've already covered looking at cardiovascular physiology and now renal physiology. In summary, what this diagram or flow chart is trying to show us is the effect and the interlinking between different body organs and systems to a response in either a decrease in cardiac output or a decrease in MAP to help then equalize that and restore that balance. And within that, the kidney has a really important role. And the role of the kidney, the way I see it, is really via the effect of the RAAS system. The RAAS system we've touched on throughout the last 2 episodes, but we haven't gone and fully broken it down into detail to see what's happening within each step of the pathway. So this is the moment we're going to go through the RAAS in a little bit more detail, starting off with the first step in the RAAS system, which is renin. We already know that renin is produced by the granular cells within the juxtaglomerular apparatus and that it's secreted due to multiple reasons, whether that's an increase in sympathetic activity, a secondary effect of circulating catecholamines on the beta-1 receptors, a decrease in renal arterial blood pressure, or a decrease in the tubular sodium chloride concentration through the macula densa. Importantly with this, remembering that renin is inhibited via angiotensin II, and there's some minor evidence it's also inhibited via the effects of ADH. When renin is released into the bloodstream, its first site of action is in the liver, where it converts that angiotensinogen into angiotensin 1 by cleaving this, and this is the rate-limiting step in the RAAS pathway. Angiotensin 1 then goes to the lungs, where it's converted by angiotensin converting enzyme to angiotensin 2. Angiotensin 2, which is the key thing we're going to focus on, is a peptide that acts via G protein coupled receptors. And it acts on multiple sites, including the CNS, the kidney, and the cardiovascular system. Within the CNS, it has 2 major effects. The first effect is on the hypothalamus, where it initiates a thirst response as well as triggers the posterior pituitary gland to release ADH so that water can be reabsorbed. The second effect in the CNS is increasing the sympathetic stimulation and depressing the parasympathetic system. By doing this, it is indirectly increasing the effects of the anterior pituitary, leading to an increase in ACTH, which is a minor stimulating factor in the release of aldosterone. It is also increasing the sympathetic discharge from our rostral ventrolateral medulla, increasing sympathetic tone, and angiotensin II is also having a direct effect on the vascular smooth muscle as it's a potent vasoconstrictor. So these 2 things are leading to an increase in vascular tone, helping to increase MAP, as well as an increase in heart rate to increase cardiac output. At the level of the kidney, it again has some direct and indirect effects. The direct effect is on the PCT, helping to further reabsorb sodium and chloride, while the main effect of angiotensin II in the kidney is manipulating renal blood flow. It predominantly constricts the efferent arteriole more than it constricts the afferent arteriole, which leads to an increase in GFR, and with this, an increase in renal plasma flow and an increase in reabsorption of fluid. This increase in reabsorption of solutes and water is further enhanced by angiotensin having its main effect by increasing the release of aldosterone from the adrenal cortex. And this is a nice way to link the third part of our RAAS system, which is the effect of aldosterone. And we haven't really spoken about aldosterone too much yet, but it's a key player in changing plasma volume through its main manipulation of sodium reabsorption. Aldosterone is a steroid that's produced in the zona glomerulosa, which is secreted by activation through angiotensin II, or by high plasma potassium levels, or by ACTH being a mild effect, or by low plasma sodium levels. The key thing to understand with aldosterone is because it's a steroid, its effects are going to be intracellular, so it's not going to be a super fast effect, rather a slow effect that it has. Its chief site of effect is going to be on the principal cells within the DCT and collecting ducts, where it increases the plasma sodium concentration via increasing the sodium-potassium ATPase pumps and the specific sodium aka ENaC pumps. These help to both increase sodium at the luminal membrane and at the basolateral membrane. And the overall effect is changing of the sodium reabsorption by only 1 to 2%, but this has a dramatic effect on changing plasma volume levels. The other effects of aldosterone is decreasing the plasma potassium levels by increasing potassium luminal channels and also secondarily by increasing the sodium potassium ATPases. Then aldosterone can also have an effect on acid base by increasing hydrogen secretion by the type A intercalated cells. And lastly, aldosterone can also have a minor effect at manipulating plasma chloride levels by increasing chloride absorption at the distal tubule. So that's a broad overview of all the little steps involved in the RAAS pathway. But there's two more hormones that we have to talk about to understand that renal regulation when it comes to that hypovolemic state. And the first one is ADH. And we mentioned it in our first learning objective, but we're just going to quickly go through exactly what ADH does at the level of the kidney. To understand this, we have to remember that ADH is a non-peptide synthesized in the hypothalamus and secreted by the posterior pituitary. It's secreted due to two reasons. Either there's an increase in plasma osmolality or there's a non-osmotic stimuli. When it comes to a change in plasma osmolality, this is only a very small change that needs to be detected by the osmoreceptors in the hypothalamus, and they say a change of 1% or more is more than enough to cause an increase in release in ADH. While the non-osmotic stimuli include the things we just spoke about, being the RAAS pathway through the activation of angiotensin II, pain, nausea and vomiting, exercise, drugs, and then the change in hemodynamics being predominantly a decrease in MAP, and with this, we need a large change in MAP of greater than 5 to 10% for there to be a change in the ADH secretion. So understanding those two stimuli, what is the effect that it actually has on the kidney? Well, there's two types of ADH receptors. There's the V1 receptors and the V2 receptors. The V1 receptors, which are G protein coupled receptors, specifically GQ, are located all across the vascular smooth muscle, and they're potent vasoconstrictors, and that's why you can give vasopressin to help improve blood pressure. The V2 receptors are the ones that we're interested in and are located in the kidney. These are G protein coupled receptors that are GS, and it's important to know that these are GS because I was asked this on my actual Viva day. Their role is predominantly in the principal cells of collecting ducts and specifically the medullary collecting ducts. Here on the luminal membrane, it upregulates aquaporin 2 channels, and on the basolateral membrane, it increases aquaporin 3 and 4 receptors. As a result, you get an increase in urine osmolality, a decrease in plasma osmolality, which is what concentrated urine is. The additional effects of ADH are the increase in urea porons within the medullary collecting ducts, increasing urea permeability, which we've spoken about, and then on this side, ADH can also have a minor direct role at increasing sodium reabsorption and potassium secretion via the action on the principal cells on the cortical collecting ducts. The important thing to distinguish between ADH and aldosterone is that on a clinical level, we've said that aldosterone is a steroid. In comparison, ADH is not a steroid. It has a rapid half-life of roughly 20 minutes, and this means it's going to have both a rapid onset and offset of effect. It's rapidly metabolized by tissue peptidases, and therefore in the initial stage where you're trying to increase water reabsorption and plasma volume, ADH is going to have a quicker effect than the effect of aldosterone. Then finally, we have the last hormone to talk about, which is ANP. ANP is atrial natriuretic peptide, and it's a peptide hormone produced and secreted by the right atrium. It's key within the renal physiology settings because we know it can alter the caliber of the afferent and efferent arterioles. This means it can alter GFR, renal blood flow, and renal plasma flow. Normally in a hypovolemic state, ANP is the thing that we're trying to decrease secretion of because we want to reabsorb more water. In normal circumstances, when we're in a fluid overload state, we're getting stretching of the heart, the right atrium, the right ventricle, and this is leading to an increase in ANP secretion. ANP receptors are again G protein coupled receptors, which have a direct effect at afferent arteriole dilatation and efferent arteriole constriction. This leads to an increase in GFR, which is then further enhanced by the relaxation of mesangial cells. The other effects of ANP is that it directly inhibits sodium reabsorption in the collecting ducts. It inhibits renin release, and it inhibits the effect of ADH. Therefore, it's the exact opposite hormone we want released in a state of hypovolemia, because what it's trying to achieve is increasing natriuresis and increased water excretion. So this is my attempt to cover this learning objective of mechanisms involved in the regulation of renal function, which I just break it down into thinking about RAAS and going through the RAAS in a stepwise manner. This brings us on to our last learning objective for today, which covers applied renal physiology, and this is describe the physiological effects and clinical assessments of renal dysfunction. Now this at face value is a pretty straightforward learning objective. Starting off with clinical assessment of renal dysfunction, clinically we characterize renal dysfunction simply as either an acute kidney injury or a chronic kidney injury. With that, we have the third subset, which is an acute kidney injury on a pre-existing chronic kidney injury. Back from our med school days, we can then break down what is the cause of the kidney injury in either a pre-renal, intrarenal, or a post-renal fashion, with pre-renal injury being a result of a failure of perfusion to the kidney. And the main physiological reason why this occurs is a decrease in hydrostatic pressure, leading to a decrease in GFR. Clinically, what you see with these patients in pre-renal injury is a low urine output state, which is mainly just driven from what we talked about, which is a decrease in GFR leads to an increased reabsorption of sodium, an increased reabsorption of water, all of which lead to a concentrated urine, and biochemically, you see this as a high urea to creatinine ratio. In comparison with an intrarenal cause, this is abnormalities within the kidney, and physiologically, this can be an effect on the glomerulus, or is this affecting the nephrons? And this will then lead to what you see. Are you seeing high amounts of proteins in the urine, suggesting that our glomerular capillary and our filtration processes have been compromised? Or are you seeing high volumes of urine output, suggesting that the nephrons aren't working and they're not able to develop the same interstitial gradient? And for this to occur, you actually need a lot of nephrons to be knocked off, more than 75% of nephrons to stop working in order for you to start losing your countercurrent mechanism. Additionally, with these type of causes, you're starting to see the imbalance of reabsorption of solutes. Therefore, you're seeing a high concentration of plasma potassium levels. You're getting a metabolic acidosis due to the inability of the kidney to reabsorb all of the bicarbonate. And along with that, you're getting decreased ability to synthesize new ammonia, so you can't remove all the hydrogen ions and form new bicarbonate? Or are you starting to see the failure of the endocrine effects of the kidney, with anemia present due to a decrease in EPO synthesis, with metabolic bone diseases due to a decrease in activation of vitamin D, and an increase in the phosphate levels and a decrease in the calcium levels. All of these signs then give you a clue to figure out where the intrarenal injury is and how long that person has had that intrarenal injury. The last classification or cause of renal injury is the post-renal cause, and this is typically obstruction of the urinary flow system. The classic example of this would be a kidney stone, and the physiological effects is now you have an increase in backflow pressure, meaning that the hydrostatic pressure within the Bowman's capsule is increased. Going back to our Starling equation, now you get hydronephrosis, you get a big kidney on the side that's affected, and because you can't filter things out from that kidney, you're getting a buildup of waste products and solutes, and wherever there's any form of stasis in the body, it's a site that leads to an increased risk of infections. And so with clinical correlation of these, is the patient have lots of pain? Are they septic? And is there an obvious cause you can see on an ultrasound or a CT KUB that shows you that you've got this post-renal cause? So I think if you have this classification system to assess renal dysfunction, breaking it down into acute or chronic, and then pre-renal, intrarenal, post-renal, you'll then be able to link in your physiology knowledge with your clinical knowledge. And I think that's a nice way to come to the end of our learning objectives in today's episode. And it segues us in nicely to look at the past SAQs on today's topics, of which there are only 3 SAQs to go over, but they're all really high yield. With the first SAQ being from 2024 first sitting, which was explain the physiological processes that cause oliguria in response to hypovolemic shock. This had a 54% pass rate and was a repeat question from the 2016 exam. As per the examiner report, there were 3 domains you needed to cover to get a pass mark, and majority of people for this question got a 3 out of 5. The 3 domains included covering the sympathetic nervous system, specifically understanding the role of the sympathetic nervous system and its impact on RAAS and ADH. Then the second domain was the RAAS system itself, understanding that it's activated by hypovolemia and how angiotensin II leads to oliguria. And thirdly, antidiuretic hormone, and understanding why the release of ADH is triggered by hypovolemia and how it leads to oliguria. I think the best model answer for this question is either Propofol Dreams or Amanda Diaz. And the reason I say this is because they answer what's at the crux of this question. And somewhere in your model answer, you need to say that this compensatory mechanism is a normal response to hypovolemic shock. You can start your model answer with simple definitions. So within these questions, you have terms like hypovolemic shock, which is just a state of inadequate intravascular volume. You have oliguria, which you can define as less than 0.5 mils per kilo per hour of urine output, or less than 400 mils a day. And then after this, I would put in a really basic summary of why oliguria is happening. Like oliguria acts as a physiological compensatory mechanism and is achieved by a number of sensors and effectors. I think this then sets up your whole answer, and then you can simply set up your answer into the sensors and effectors. Within the sensors, you have your high pressure baroreceptors, i.e. your choroid sinus and your aortic arch, and with these, when intravascular depletion goes above 10%, that's when they start to activate the sympathetic nervous system. You have your intrarenal baroreceptors, or your juxtaglomerular apparatus, which is going to recognize your afferent arteriole stretch, and remembering that you have normal autoregulation mechanisms which maintain a normal renal blood flow and a normal GFR across an autoregulation zone between a map of 70 to 170. And when things fall out of this, this is going to be your biggest trigger for releasing renin, which is going to be your main effector pathway. You have your macula densa, which as a response to a decrease in glomerular filtrate and a decrease in sodium and chloride reaching that juxtaglomerular apparatus leads to an increase in renin release. And then you have your osmoreceptors recognizing a change in osmolality, which is very sensitive, roughly 1 to 2%, which can lead to an increase in ADH. Then moving to your effectors, you would just have your three domains that the examiner report mentioned, being firstly your sympathetic nervous system, which is increase in activation due to the baroreceptors, and this will then lead to central effects as well as intrarenal effects and constrict both the afferent and efferent renal arterioles. With this, you then have the effect of RAAS, which is going to be the main place you're going to spend most of your time. The key thing with RAAS is that you need to clearly lay out what is the effect of angiotensin II, which we've discussed as a direct vasoconstrictor, a constrictor of preferentially the efferent arteriole more so than the afferent arteriole, which leads to a preservation of GFR, increase in aldosterone activation, increase in ADH release, and a direct reabsorption of sodium and water. As a consequence of this, as you increase sodium and water reabsorption, both directly and indirectly, you're going to get decreased urine formation. And accompanying this effect is the effect of ADH, which has a dual purpose of increasing aquaporons for water reabsorption, but also increasing urea porons to increase the interstitial medullary gradient. This is a key term that you want to put in, and you want to link in a few things here. The first thing you want to link in is the increase in sodium, potassium, and chloride reabsorption via the effects of aldosterone and angiotensin II enhances that interstitial osmolality, which is 50% driven by the sodium chloride concentration, but the other 50% is via urea reabsorption. And the increase in urea porons, specifically in the medullary collecting duct, leads to increased urea going into the interstitium, increasing the osmolality to a maximum of 1200 to 1400 milliosmoles per kilo, which leads to further reabsorption of water into the vasorecta, increasing plasma volume, but consequently leading to a decrease in urine output. And what is key with the ADH response that I would put in is a bit of clinical context. Because when you don't have ADH working adequately, you can be in a hypovolemic state and still be producing high amounts of urine output. And this is what exactly happens in conditions like diabetes insipidus. So ADH is the main player which helps to make oligourea in a hypovolemic state. And so while it seems like I'm repeating myself, this is a really important concept to understand because it's really what majority of the SAQs, when we talk about either oligourea, dilute or concentrated urine, revolve around is you understanding the role of ADH and that countercurrent mechanism which we spoke about with our first learning objective. And this then links nicely to our next SAQ, which was asked in 2022 second sitting, which was describe the physiological mechanisms by which renal collecting duct is able to produce both dilute and concentrated urine. This had a 56% pass rate, and the major domains here assessed your ability to relay the mechanisms that result in presentation of a hypertonic filtrate to the collecting duct, the role of ADH in the collecting duct, including control mechanisms, and the role of medullary tonicity in the movement of water. And for this question, the ketamine nightmares answer is a really good logical way to think about all the things we've talked about on today's episode. Starting off with your model answer, saying some basic facts like the main determining factor for producing either concentrated or dilute urine is the effect of ADH. This can then lead on to saying majority of water and solutes are reabsorbed in the PCT. We know that the rough mark for majority of things is 65% are reabsorbed in the PCT, and that manipulation of urine concentration mainly occurs in the collecting ducts, principally the medullary collecting ducts. The way that this occurs is through the countercurrent mechanisms and the manipulation of the interstitial medullary osmolality, which is driven by the countercurrent multiplier, the countercurrent exchanger, and urea reabsorption. Saying those things early then allows you to flow on nicely and say that the loop of Henle has selective permeability. Within the ascending loop, it's permeable to solutes, and the descending loop is permeable to water. In doing so, a gradient is established within the loop of Henle and the medullary interstitium, and that this gradient is used by the countercurrent exchanger, aka the vasorector, to then reabsorb water and solutes. The key thing you want to mention with the vasorector is that it flows in close proximity to the loop of Henle, it flows in opposite direction to the loop of Henle, and its flow is slow to allow maximum reabsorption. And then you have the effect of urea controlled by ADH, which is the main source of changing the osmolality within the interstitium and the concentration or dilution of urine. This is where you would spend a little bit more of the time of this question, maybe 3 to 4 minutes. And again, you could break it down into the senses for the ADH and the effects of ADH, exactly repeating what we talked about with our last SAQ. Noting that if you have increased ADH, you get increased urea porons, increased aquaporons, all of which lead to an increase in interstitial osmolality, and the end result is a concentrated hypertonic urine. And really along these lines, you have our final SAQ for today, which was asked way back in 2015 and actually asked twice in the same year, which was outline the physiological changes that may explain why an otherwise well patient may have a reduced urine output intraoperatively. And this had a 60% pass rate, and the main thing I took from the examiner report was using a logical discussion style of that pre-renal, renal, and post-renal causes of why a patient intraoperatively may have a low urine output. If you don't like that approach, you could also structure your model answer using the Starling equation for this question, or simply just do what Ketamine Nightmares does and describe the determinants of urine output, which will be that urine output is equal to filtration plus secretion minus reabsorption. And if you then think about these three things logically, you can then have enough to talk about on what might happen to a patient intraoperatively. Starting off with changes in filtration, which can be mainly predominantly driven by a decrease in MAP or falling out of our normal autoregulation zone for the kidney, which again is a MAP between 70 to 170. Clinically, this could happen in an anesthetized patient due to the effects of IV induction drugs or the effects of regional anesthesia. Then you can go into the factors that increase reabsorption. And really, I view this question in the similar way as to the question of why do you get oliguria in hypovolemic shock? Because they're really trying to ask the same thing in terms of invoke you to understand what are the physiological processes that are happening. So with that question, the three domains they want you to cover were understanding the effects of the sympathetic nervous system, ADH, and RAAS. So really, those are the three things you're going to talk about in this question again. The key thing to understand with those three factors in this question compared to the hypovolemic patient is that the trigger for these three responses is a little bit different compared to the hypovolemic patient. They've specifically mentioned this is an otherwise well patient. So here, the release of ADH is happening because of stressful response from the surgery and may or may not be happening due to a decrease in MAP and the effects of some of the drugs that you're giving. The increase in RAAS is happening because again, you're getting an increase in sympathetic stimulation from pain, which leads to an increase in circulating catecholamines, leading to an increase in beta-1 activation at the granular cells. And that along with this RAAS, you can also tie in some of the clinical aspects associated with what might be happening in surgery. Classically, you can think about things like laparoscopic surgery causing an increase in intra-abdominal pressure, which will be changing your glomerular filtration. You can be thinking about changes in position. So if a patient's in a reverse Trendelenburg position, they might be getting decreased preload, leading to a decrease in MAP and further decreasing the filtration pressure. And adding in those kind of things into the clinical context of this question might help you to just get a few extra points across, which might take your answer from a 2 to a 3. So that's the end of our episode today and our end of our renal physiology series. Thank you guys again for listening. And if you have any questions, send me an email. I wish you guys all a Merry Christmas and a Happy New Year. And I'll be back next year covering a whole bunch of new topics and new series. So until then, best of luck with your studying, and I'll catch you guys next time on Count to 10.